Assalamu alaikum wa rahmatullah. Thank you, Dr. Zaid, for your kind introduction, and thank you for the organizers for their invitation. I was asked to talk to you about thoughts in choosing therapies in the relapse refractory setting, and this complements what Dr. Apsi just excellently presented. So these are my objectives. Very brief overview on CLL and prognostication. It was already very well covered before. Treatment landscape in the relapse refractory setting. Cycling of therapy, which I think is becoming a more challenging treatment, and how to go around that. I will also talk about toxicities of some of those treatments, particularly the novel agents, and finally some future directions. I don't think the pointer works, so I'll just hopefully will listen to most of what I'm saying. As you know, CLL background's already been presented. It's a malignancy that we encounter as hematologists not infrequently. It's common in the US, it's common in Saudi Arabia. The patients generally are in their early 60s to early 70s. That's where most of those patients present. The median age of the patients that we see in our practice where I work is somewhere in their mid 60s to mid 70s. And we see about 15 to 20 patients per year, so it's not an uncommon malignancy. Patients are very variable in their presentation. We see patients that progress within 6 months, and we see patients that never require treatment, so it's a very heterogeneous group of patients, as you know. Prognostication is based on a number of things, but FISH is an extremely valuable tool to us, particularly when it comes to P53 or TP53 mutation or 17p deletion. Actually, this is not a group of patients that is frequently encountered. It represents less than 10 to 15% of the total CLL patients, but it has great implications in terms of how we want to treat these patients, particularly with the treatments that we have today. So when we choose therapies, Dr. Apsi already talked about the frontline setting. So we think about age, we think about the FISH or cytogenetic status of the patient. We think about the heavy gene mutational status, and this is a test that's become locally available. In the relapse refractory setting, we consider all of the above, plus we consider what treatment the patient has had. The patients that we will see today, the kind of treatments that they had is probably chemoimmunotherapy for many of them. Some of them have received novel therapies, but probably in the next 5 to 10 years, the majority of those patients probably would have started on novel treatments because, as you've seen, the guidelines are changing. One thing that is also very important is the remission duration that the patient has achieved while from the prior therapy that they were treated with. One thing that is also very important, it's not here on the slide, but whenever we talk about progression-free survival in CLL, yes, it's important, etc., but it may not necessarily mean the same thing compared to lymphoma, for example, or in leukemia. And the reason why that's the case is because at the time of progression, it does not automatically mandate subsequent therapy. So someone may progress today, but they may not need subsequent therapy for another 6 months. So to me, something that is also equally important as progression-free survival is the time to subsequent therapy from the previous therapy. But this is not something that is always available from the evidence or the literature that we have. The unresolved questions that we have today, and hopefully we will have over the next few years, is should we use sequential monotherapy? You saw the NCCN guidelines in terms of how you should start treatment. So should we use ibrutinib alone or ibrutinib rituximab indefinitely until progression or intolerance, or venetoclax, etc.? So should we use sequential therapy until progression, or should we try to combine these therapies in a time-limited manner? And the goal is to try to achieve deep and lasting remissions and try to hopefully achieve some sort of a treatment-free remission or maybe even cure. The last issue is timing to allogeneic transplant. This is something that used to be talked a lot about. In fact, I have taken care of many patients who have received allogeneic transplant for CLL during my fellowship. Now we hardly see any patients. In fact, in the last 4 or 5 years, I cannot think of a single patient that we, in fact, have underwent an allogeneic transplant for. And the reason for this is twofold. I think part of this is the age of these patients. Many of those patients are not eligible for allogeneic transplant in the first place. But the second reason is also the advent of all these novel therapies, and typically all those patients that underwent transplant were the 17p deleted patients. Now you don't only have one option, 2 options. You have multiple options for these 17p3 deleted patients before you start considering transplant. So this is a schematic of what a CLL cell looks like, and essentially the targets that we have. So we are targeting the CLL cell from multiple angles, from a BTK inhibitor point of view, from a BCL2 inhibitor, from a CD20 target, and also from the inside, from another kinase on the inside, which is the PI3K kinase, which we have 2 drugs that are approved and more in clinical development. So previously treated CLL patients, this is what the NCCN guidelines look for, and similar to the frontline setting, it looks almost identical. So when we stratify patients with comorbidities or without comorbidity, it really hardly makes any difference. So the recommendations are sorted out not in terms of what is better, so acalabrutinib, ibrutinib, venetoclax, Duvelisib, etc. So they're not sorted out in a preferred manner, but they're sorted out in an alphabetical manner, and this is something important to keep in mind. So now we have long-term follow-up or long-term updates about the trials that have led to the approval of these drugs, and this is one of the earliest, if not the earliest trial that was conducted. So this is the trial, in fact, that led to the approval of ibrutinib in the relapsed and refractory setting. So this was a phase 3 ibrutinib versus Ofatumumab. For Dr. Basim, this is Ofatumumab استخدم. So obviously the biggest criticism when this trial was conducted and reported is that, are we really comparing ibrutinib to a standard of care? So would anyone use Ofatumumab to treat patients in the relapse and refractory CLL? And obviously this is a valid point. So this is the trial that led to the approval based on a huge difference in PFS. So you can obviously see that ibrutinib was significantly better compared to Ofatumumab. And even if you don't, and even considering the fact that Ofatumumab is not an acceptable standard of care, you see if you just look at how well the ibrutinib patients do, particularly keeping in mind that many of those patients had high-risk features. And when you compare this, obviously it's not a randomized comparison, but when you see how historical controls did with FCR or BR, or with unmutated immunoglobulin status, then you can appreciate the value that ibrutinib has in this setting. So this led to the approval of ibrutinib, as you know, and this led to this drug quickly moving to be tested in the frontline setting. Again, looking at different risk groups, so you see when we select for patients that have deletion 17p or having an unmutated status, you see that the drug continues to do quite well. So, and the overall survival, again, crossover was allowed, and again, with the analysis of intention to treat, it becomes harder to prove an overall survival advantage. The second drug that is important to us is venetoclax. So venetoclax was tested with rituximab compared to BR in previously treated patients, and this is the famous MURANO study. Again, a randomized trial had about 200 patients in total, and the primary endpoint is again PFS, as it is the case in the majority of the CLL trials. We see that venetoclax is clearly superior to bendamustine rituximab, and bendamustine rituximab is an acceptable or was a very acceptable standard of care during the time that the trial was initiated. And in terms of overall survival, there's probably a minor difference, but is fairly inconsequential or is of little clinical significance. When they looked at predictors in terms of what helped us to try to anticipate or predict disease progression, so when they look at MRD, so as expected and as is the case in the majority of hematologic malignancies, patients that achieve negative MRD at end of treatment do better. Patients that have deletion 17p or TP53 mutation tend to do worse. And patients that have 11q mutation, so this is a second high-risk cytogenetic group, or the ATM deletion, they also seem to do worse. And when they looked at patients that had deletion 11q but without the 17p deletion, then that ATM deletion component tends to lose its clinical or statistical significance. The safety features or the adverse events that were reported with venetoclax is what we already know today, is that it's associated with a high incidence of neutropenia, even compared to chemotherapy. So even when you look at bendamustine, there's more neutropenia with venetoclax. But interestingly, when we look at febrile neutropenia, the incidence with bendamustine is higher. The third drug is idelalisib. So Idela, with or without rituximab, was again tested. So rituximab placebo or rituximab-idela, and followed by Idela at the time of disease progression. And when they looked at the group that were treated with idelalisib and essentially stratified them based on high-risk features, so again, TP53 mutation or 17p deletion, there was really no difference. So even though this was a relapse refractory setting, this led to the approval of the drug and even to be considered in the frontline setting, with one component that we will talk about soon. Duvelisib is another drug approved. The impact in terms of its PFS is not as profound compared to the other drugs that I've just shown you, but nonetheless, it still led to the improvement of PFS, which ultimately led to the approval of this drug. Now, if we look at both Duvelisib and idelalisib are PI3K kinase inhibitors. They target different subunits within the PI3K. However, what is shared amongst them is a side effect profile that is very similar. And specifically when it comes to idelalisib, the incidence of colitis and pneumonitis is significant enough that it led, and in fact, even incidence of hepatic injury that was fatal in some cases, led to a black box warning for this particular medication. And it can be considered in the frontline setting, but only if the patient is not eligible for other therapies. Finally, the acalabrutinib was compared to idelalisib rituximab or BR in previously treated CLL patients. And this acalabrutinib, as you know, is another BTK inhibitor. It's already approved in mantle cell lymphoma. And initially, the drug was being developed in a way that it would have a more favorable toxicity profile compared to ibrutinib, particularly when it came to the bleeding risk and the cardiac toxicity, the atrial fibrillation and hypertension. We will be seeing the side effect profiles shortly. The primary endpoint was again PFS. And if you see, what you see here is acalabrutinib was clearly superior to idelalisib or BR. And in fact, when you look at the curve, it's really quite impressive where you see that at 2 years at follow-up, the majority of the patients are progression-free when they are being treated with acalabrutinib. So this certainly is another exciting option. The drug is currently being analyzed or studied by the FDA to see where it can fit in the treatment of CLL patients. When we look at the safety profile of acalabrutinib, as I said, it's meant to be or meant to have a different adverse event profile compared with ibrutinib. We see that atrial fibrillation still happens, bleeding still happens, and hypertension still happens. So these perhaps at a lower extent compared to what you would see. But the other component that is different is the incidence of headaches is certainly higher compared to what you would see with ibrutinib. Now, the one point that I wanted to talk about with regards to hypertension is that it's not just about the absolute incidence, and it's not just about the grading, is it grade 1, 2, or 3, but it's also about the incidence over time. So the incidence perhaps in 6 months or 1 year or 2 years is in fact increasing. So this is a cumulative effect where it can be 3% or 4% at 6 months, but it may reach much higher numbers the longer you follow up these patients. And this is true with both ibrutinib and acalabrutinib. One interesting study was a phase 1 to 2, looked at acalabrutinib specifically in patients that have failed ibrutinib due to side effects. So this was not due to progression, and which usually is the case because of a mutation, but it's because of intolerance or adverse event and the like. And what they observed in these relatively small number of patients is that the majority of patients did not experience the same side effects that they had on ibrutinib. So if the reason for stopping ibrutinib, for example, was bleeding and then the patient was switched to acalabrutinib, in 3/4 of those patients it did not recur. And in the remaining quarter of patients, it was split between recurrence at the same grade or lower grade. Really only a very small proportion of patients had a more severe adverse event profile. Okay. Now, the issue that we have now, I presented you data on ibrutinib, venetoclax, acalabrutinib, idelalisib, duvelisib. So these are 5 drugs that we have that are possibly being used or could be used in the relapse and the refractory setting. But the challenge is that they were not really directly compared head-to-head and probably will never be compared head-to-head. So what we end up relying on is essentially real-life data or retrospective data that is pooled from one institution, two institutions, or hopefully multiple institutions, where we can see how these patients do when we essentially fail one drug and then we want to initiate the other drug. What is the likelihood of response? So if we look at some of this real-life data that's available to us, and then we see if a patient had failed ibrutinib or idelalisib, because these were some of the earlier drugs that were available to us, and they were initiated on subsequent therapy. So you see that if the patient was initiated on an alternate kinase inhibitor, the likelihood of a response is about 50%. The majority of those all of those responses are in fact partial remissions. The best case scenario that we can see, if a patient fails ibrutinib or idelalisib and they were started on a BTK inhibitor or BCL2 inhibitor, they can get a response in about 3/4 of those patients. And so based on the limited data that we have, it appears that this probably is the best approach, and I have another slide to show you on that. Now, to use chemoimmunotherapy or CD20 monoclonal antibody after failing a novel agent really does not result in a lot of successes, as you can imagine. This phase 2 trial specifically looked at venetoclax in patients with CLL that have failed ibrutinib or idelalisib, and they looked at a reasonable number of patients, of about 130. And what we see essentially is that if you try venetoclax following failure of a kinase inhibitor, you get a response in the majority of patients with a progression-free survival that is somewhere around 2 years. So half of those patients are going to fail venetoclax within 2 years, but it's still a reasonable approach that you can have in these patients, that most of them have in fact not been on a large number of therapies before. The median was in fact 4. So the majority of those patients have failed chemoimmunotherapy, a novel agent, and now a second novel agent. So this probably is the best approach, and this is closer to a real-life scenario that we may have. So for example, in my practice, I see patients that have been, the majority of my patients that I see that have been treated with a chemoimmunotherapy approach. So when they fail that, they're tried initially on ibrutinib, and when they fail that, the next logical step is probably venetoclax in combination. So usually venetoclax with rituximab. Now, post-venetoclax failure, we really have very limited literature, and here is really, I would say this is a case, doesn't even qualify as a case series, so it's almost a handful of patients that have been tried on ibrutinib after failure of venetoclax. They seem to respond, but really I would say that we just don't know, and we have to wait until more real-world data emerges so that that can guide us in terms of how to proceed. This is an extremely important study, and the story on this study is not resolved yet. So I'll just spend a couple of minutes to explain the layout if you were not familiar with it. So the CLARITY study was designed in a way to combine both ibrutinib and venetoclax to try to do a couple of things. So number one, try to get deep responses and try to discontinue therapy on patients that managed to achieve a negative MRD status. So what they did in the study is that they gave 2 months of ibrutinib as a lead-in phase. So number one, to minimize the risk of tumor lysis, and then number two, to try to deepen the response and see how patients do. But then when they started the venetoclax 2 months in, they do the initial ramp-up phase over 5 weeks. So they start at 20 milligrams, and then they escalate over 5 weeks until they finally reach the 400. But then what they did is that they analyzed patients at different time points. So you see they analyzed them at 6 months of combined therapy. So this is 8 months since the beginning of ibrutinib. And then they analyzed them again at 12 months and then at 24 months of combined therapy. So this is 8 months, 14 months, and 26 months. So what they do is that patients that achieve a negative MRD status after 6 months of combination, they stop both drugs at 1 year, okay? And patients that achieve a negative MRD status after 1 year, they stop both drugs at 2 years. And patients that don't achieve MRD negative status by 1 to 2 years, they continue on either ibrutinib or venetoclax, and they created an amendum. But I'm most interested in the first two categories. So these patients that stop after 1 year of therapy and patients that stop after 2 years of therapy. So what do we know now is the following. So the first thing is that the majority of these patients responded. Half of those responses were complete, and almost all of those complete responses were negative MRD or unmeasurable MRD responses, okay? And you see that here. So unmeasurable MRD in the peripheral blood is 57% and 39% in the bone marrow. So this is fairly impressive. Now, but we already know this from the frontline trial that Dr. Apsi just presented to you. But what I am interested in is that can we stop these drugs? So patients that achieved negative MRD at 6 months, the drugs were stopped at 1 year, and there were 20 patients so far, and these patients were followed from 1 year to 2 years, and so far they remained MRD negative. So this is based on preliminary data that we have from the International Working Group of CLL 2019 that was just presented 2 months ago. So obviously we're interested in how these patients do long term, so over the next 1 to 2 years, and are we able to stop, and also the second group of patients, so those patients that don't achieve early MRD response, but achieve early negative MRD at 1 year. So again, can we stop the drug in this case, and how do they do long term? So I think with this kind of approach, we may end up changing, depending on how the results look like. We are certainly looking at a different way in treating CLL compared to how we treated them just 1 year ago. So in summary, targeted treatments have really improved how we treat CLL patients and have relegated chemoimmunotherapy really to a backseat that really only a small proportion of patients would be eligible for this. And the challenge now is how to best use these treatments. So should we use them in terms of sequential approach? So we just use one drug. When the patient fails, we use the other one, and then we use the other one, and then we know that we have 5, 6 options, and probably even more options coming down the line. Or should we try to do more of this combined approach? And I think this is probably the way it's going to go if the MRD story pans out. So if these patients remain in remission, particularly with the longer follow-up, then I think the strategy certainly makes sense both in terms of toxicity profile and in terms of a financial profile, financial sustainability point of view. So we will see. And as you can imagine, there are plenty of trials to begin with. CLL has really been the story that's been evolving at least over the last 5 to 6 years, that we will continue to get updates at almost every single ASH. I have some more slides about optimal dosing and then toxicity management. And I think I will try to...
You still have 5 minutes.
Okay, so I'll try to go through those quickly. So, most of this is a review for the audience. So we know how ibrutinib, idelalisib, and venetoclax are dosed. Just certain caveats about ibrutinib with its toxicity profile, the cardiac and the bleeding, the idelalisib with its colitis, pneumonitis problem, and venetoclax mainly neutropenia and tumor lysis syndrome that requires attention. So dose modification, this is from the drug insert. So if you get a grade 3 or worse toxicity, or if you get a grade 4 hematologic toxicity, then you stop the drug and then you restart at the same dose. And if it recurs, you progressively lower the dose. So this is fairly straightforward. One thing to keep in mind is to try to keep the drug interruptions to as short duration as possible, because the longer the drug interruption, the worse is the outcome. And this is based from real world data from the UK. Ibrutinib, this is already, we covered all of this already in terms of bleeding, diarrhea, etc. So by Dr. Apsi and myself, and we can certainly talk more about this if anyone is interested. The issue of anticoagulation or antiplatelet therapy while on ibrutinib is an important one. So generally speaking, warfarin use with BTK inhibitor is not a good idea. Apixaban use or generally the NOACs is feasible. We tend to lower the dose. Antiplatelet and an anticoagulant combined with ibrutinib, probably not a good idea. So we try to minimize the use of more than one antiplatelet or anticoagulant together. And if we have to, for various reasons, we have to appreciate that the risk of bleeding is going to become higher. Hypertension, as I said before, it increases with time. So the incidence at 1 year and 2 years, 3 years becomes cumulative, and it easily reaches 20 to 30%. So that's something that has to be kept in mind. Personally, and I had to deal with this, where patients, when they come in 2 or 3 years following ibrutinib, they may have a blood pressure in there easily that reaches grade 3 or 160 systolic and above. When we look at the incidence from pooled analysis on atrial fibrillation, we see that it's somewhere between 5% or so, and that has to be kept in mind when these patients go on anticoagulation and the risk of bleeding, etc. How to manage atrial fibrillation, fairly straightforward, and it's available very easily. Idelalisib adverse events, mainly the issues relating to colitis, pneumonitis, And in fact, this incidence is not only at the beginning couple of months, this can be seen even up to 2 years following initiation of treatment. So this is something that has to be kept in mind. And it really requires active surveillance to make sure that early symptoms are picked up and patients are managed appropriately. Venetoclax, the main issues that we see with it is tumor lysis, and this has been well described. We know how to stratify patients and into low, medium, and high risk, and we know how to ramp up the dose over a 5-week duration period. For some reason that is not clear to me, this does not seem to happen in acute myeloid leukemia where you expect the risk of tumor lysis to be higher. But anyway, this is what we see, and this is how it is. Risk of neutropenia, again, with venetoclax is relatively high. So certainly this requires ongoing follow-up. Now, so where do we see ourselves? I'll wrap up with a couple of slides. So in terms of future directions, these are some of the ongoing trials in CLL. We see that a lot of them target the untreated patients. And here we're talking about, obviously, the approved drugs in different approaches. So the next few years are certainly may result in further changes in the treatment paradigm in CLL, and the future will, hopefully, things will become more clear in the next few years, but maybe not. We have other drugs that are also under clinical development, both BTK inhibitors, PI3K kinases, and other mechanisms of action, as well as CAR T therapy, where it appears to be working, and for some reason, exposure to ibrutinib enhances the response that is seen with CAR T therapy. Why that's the case remains unclear, but also this is an evolving story, so it depends on how the treatment approach in CLL evolves over the coming years. We may further appreciate how to utilize CAR T therapy in the overall treatment landscape. So again, in conclusion, novel agents are really changing the way we treat these patients, and we're trying to learn how to incorporate it into our clinical practice. So the future will be bright, hopefully, for CLL patients. And thank you.
Thank you, Dr. Dulmaj, and then the floor is open for discussion, as usual.
ما حكيت لنا عن ريختر.
Richter transformation. Richter transformation is a complicated story in CLL because, in fact, there are two kinds of Richter's transformation. It's the same as PTLD, where it can be monomorphic or polymorphic. It's not really clear how. So essentially, you're evolving into, as you know, into a new disease. And the use of novel agents like ibrutinib might work, and there is some evidence that ibrutinib use can result in some responses, but most of those responses are partial. And the treatment of Richter's really moves back to the use of chemoimmunotherapies and possibly even autologous transplantation.
Autologous, not allogeneic.
Well, it depends if the patient is fit. You know, most of these patients are unfit. Personally, I patient with Richter's transformation undergo an allogeneic transplant. I've treated a few with autologous transplant, but allogeneic I have not.
Dr. Salim.
Thank you very much for the lecture. I think it is very important to keep in mind the advantages of the other options. So, for example, the venetoclax-based regimen, the time-limited duration, I think is very important. And also now we have the third option that was just approved yesterday. We were talking, acalabrutinib is actually approved now yesterday by FDA and Canada and Europe, Australia. So it is in the upfront as well as in the relapse. So it's good to have more options. I don't think we should think about them as all cases are ibrutinib. I think we should explore all of these options to our patients and tell the advantages and disadvantages for each. And trying to have this informed decision by the patient, because some patients will prefer to use time limited instead of, you know.
Yeah, absolutely, no. So this is a very important point, and thank you for raising this. Certainly it's not, as I said, the treatment approach is changing. So my personal approach, if we manage to get, so what do we know so far about all of these drugs? So number one, partial responses is what we see with the majority of cases when we use them as monotherapy, or even when they're combined with a monoclonal antibody. So what this means essentially is that it's an ongoing treatment until progression or toxicity. So when we're trying to make a decision of a BTK inhibitor, to me at least, I don't see a big difference between both options. So the adverse event profile seems very comparable. There's no, unless there's a financial reason, that could be a reason, but at least from a medical standpoint, both BTK inhibitors for CLL management are very similar to me. In terms of the venetoclax, this is a very, very well taken point. So if you're able to treat with a limited or a finite duration of time, so it's 12 months, venetoclax, obinutuzumab, or rituximab, obviously this is more favorable than ongoing treatment forever. But all of this may change if in the next 1 to 2 years we realize that we can cure half of these patients of CLL if we just treat them 1 year of combined venetoclax, ibrutinib or BTK inhibitor for 1 year, and then we can have a treatment-free remission that can last 2, 3, 4 years. I think probably this is going to trump a lot of the currently existing approach. So this is what I have about it.
Thank you, Dr. Mosab. So back to the same point of time-limited treatment. So I'm not sure, I want your comment on that. I'm not sure how much ibrutinib, venetoclax, or how much ibrutinib is adding to venetoclax or venetoclax adding to ibrutinib. Because from the data, it appears that the MRD negativity is higher in the MURANO rather than the Clarity trial. So we know that from the MURANO now, the sustained progression-free survival at 4 years is approximately 57%. So do you see that the Clarity will have a more impact on the future direction of therapy?
Now, the challenge sometimes whenever we do cross-trial comparison is the numbers don't necessarily, so I don't think we can compare the number here compared to, in one trial compared to another trial, and we say that if the approach is, this approach is better than that. But what we can do is the following. If we're able to achieve MRD negativity, which is a fairly new concept in CLL, if you will, we've only been seeing it in reality over the last couple of years. So if we're able to achieve this concept, this may be the goal, and how we achieve that could be variable. So the combination is one approach, or of these particular two drugs. But for example, if there's a trial that's developed in the future with another BTK inhibitor or with a PI3K kinase backbone, for example, and if we're able to achieve a deeper response, then this essentially may be a more favored approach. I don't know if I answered your question or not.
How much the addition of ibrutinib will add? We know that ibrutinib as monotherapy does not have a high CR or MRD negativity. This is not your aim. So the aim
and that's the same goes for venetoclax.
So no, with venetoclax, with combination of monoclonal antibodies, you have a high CR rate and a high MRD negativity, both in the, especially in the peripheral blood and in the bone marrow. But that's not the case in ibrutinib. So when you add ibrutinib to venetoclax, how much that would add in terms of MRD negative CRs and deep responses?
So I don't know the answer to that. And the concept of adding ibrutinib as a leading phase was part of it to decrease the risk of tumor lysis. But I'm not, in fact, the discontinuation that you see with the combination is probably the most active. Let me rephrase this in another way. If we manage to, in fact, can you remind, the number, in fact, from the MURANO trial now escapes me. Now, what was the MRD rate with obinutuzumab, venetoclax?
I'm not sure, but I think something.
I don't think it was higher. I don't think that it was higher than.
It's something like in the 50. I'm not sure.
I highly doubt that. So I highly doubt that the incidence of and the reason for this is the following. When you use venetoclax as monotherapy, the overall response rate is somewhere between, in the relapse refractory setting, obviously here I'm talking. And this is a very important point when how we compare, because this combination that led to the discontinuation of the combination, I mean, it was tested in the relapse refractory setting. So let me show you the trial again. So we cannot compare that way. So this is where, where is it? No, because I think it's important to emphasize this point here. So when we say that the negative MRD rate with the combination of 50% in the relapse refractory setting in patients that have received multiple lines of therapy, this is very different when we say that venetoclax or obinutuzumab have achieved MRD, or whatever a combination, patients have achieved this kind of MRD negativity in the frontline setting. So we have to be very careful about that as well. Anyhow, I'm not sure that we that I completely answered your question, but we can certainly talk more about it later on.